Welcome everyone and good afternoon. Thank you so much as always for taking your time to be a part of our wellness program event here at the Premier Medical Plaza. I see a lot of familiar faces, which makes me think that you must really be enjoying our programs. So today we're going to have Dr. James Anderson speaking today on ADHD, and make yourself at home. Thank you.
I would like to echo our thanks to you for coming today on behalf of Cornerstone Healthcare and High Point Regional Health System. Dr. James Anderson is going to be speaking to us today about ADHD, and I want to give you a little bit of history about Dr. Anderson. He's been in our community 15 years now. Dr. Anderson has an undergraduate degree from Baylor University. He got his medical degree at Baylor College of Medicine in Houston, and he was a chief resident there. He is board certified by the American Board of Pediatrics. But I really think what I would like to say about Dr. Anderson that will kind of epitomize him and set you up for his presentation is I have the pleasure of running around the triad representing Cornerstone Healthcare. And one of the most wonderful parts of my job is when I see patients who say, oh, this such and such is my doctor. I absolutely love he or she. Please, let them know how much I enjoy working with them. They take such good care of me. And inevitably, the one doctor that I get the most kudos about is Dr. Jim Anderson. It doesn't matter where I am. I think one time I was waiting in line in the ladies' room, and someone came up and said, oh my gosh, Dr. Jim Anderson from Cornerstone, you work with him, please tell him how much. So I just want to say thank you for giving me the opportunity to talk to people in line at the ladies' room.
Well, thank you all very much for the opportunity to be with you all today. What I want to do is to talk a little bit to you all about ADHD, Attention Deficit Hyperactivity Disorder, which is something that I have really gotten to know a whole lot about, and I've had the pleasure of taking care of a large number of patients with Attention Deficit Hyperactivity Disorder since I've come to town. I started initially with the High Point Infant and Child Clinic. I don't know if those of you all know Dr. Bill Michael. And Dr. Michael had really grown to develop ADD as a specialty within the practice. Dr. Michael retired shortly after I came, and I had the pleasure of starting off with a number of his patients with ADD, and have developed quite a large practice in this area. And so he has been a tremendous mentor as I've learned a lot about the disease, and hopefully I'll be able to share some of that experience with you all. And at the end, this is your time, so I want to make sure if y'all have any questions or if I'm not clear about something, please don't hesitate to let me know, okay? So the first thing I want to let y'all know about is that ADHD is actually something that's been around for quite a long time. It's not just a product of the 21st century. I have a little snippet here on the slide written in 1863 by a poet by the name of Heinrich Hoffmann, where he wrote poems about childhood behavior. And the poem reads, this is just an excerpt from it, Philip, stop acting like a worm. The table is no place to squirm. Thus speaks the father to his son, severely says it, not in fun. Mother frowns and looks around, although she doesn't make a sound. But Philip will not take advice. He'll have his way at any price. He turns and churns, he wiggles and jiggles, here and there on the chair. Philip, these twists I cannot bear. Sound like some kids you know with ADHD? Okay. There's also another poem called Johnny Head in the Air, which really looks like one who has the inattentive aspect of ADD. So it's important to really know kind of how ADHD evolved. It was first described in 1902 by a gentleman by the name of George Still, who first diagnosed it as a clinical entity. But what was true at the time, they really thought that everything was a deficit of moral control, but he did think that there was some neurological basis to it. In the 1930s through the 1950s, as we learned more about the brain through brain injuries from World War I and World War II, they began to look at ADHD as potentially a little bit of minimal brain damage, where they thought that these kids may have a little bit of mental retardation, be emotionally disturbed, or socially or culturally disadvantaged. However, that was not a very good definition because kids, if they did have minimal brain damage, would have some of the mild sequelae that we see with cerebral palsy, and they do not. So in the late 1950s and early 1960s, they said, well, maybe these kids have normal brain mechanisms, but it has to do more with the neural pathways. So it's a little bit of minimal brain dysfunction. Again, that didn't really play out because, again, you would see some subtle neurological signs in these kiddos, and that is often not the case. In the late 1960s, they really started to focus on hyperactivity as a behavior as being part of the definition of this disorder. And they started to call it the hyperkinetic reaction of childhood, or the hyperactive child syndrome. And they said, because we got a bunch of boys who are really hyperactive, but they're not retarded and they don't have learning disability. But that was a lousy definition because obviously it only focused on one of the many aspects of ADD and ADHD, but it also missed all the girls who had it, okay? And at that point in time, paradoxically, was when they started to use stimulant medication for ADD and ADHD. Now, when even going through my residency, I thought that was crazy. Why would you give a kid who's hyperactive a stimulant? Okay. We'll explain here in a few moments actually how that does make sense. Now, I'm not quite sure how they came upon that thought process, but right now we do have a much better understanding of how that's helpful. In the 1970s, the American Psychiatric Association got together and they created a book called the DSM, or we call the Diagnostic and Statistical Manual of Mental Disorders. Terrible name for a book, but we are on the 4th edition. And what they did is they took consensus as well as research data to try to classify what it takes criteria-wise to have a particular disease entity. So what classifies anxiety disorder from obsessive-compulsive disorder, from ADD, from post-traumatic stress, from schizophrenia, so that we're all talking apples and apples and oranges and oranges. That was when ADD or ADHD started to develop the inattentive component. Now you'll notice I tend to use ADD and ADHD interchangeably. When ADD was first discussed, the term ADD was used for the inattentive aspect of ADD. ADHD was defined to use to mean when they had a hyperactive component. Nowadays, we actually specify the component, so those two terms are used interchangeably. So I didn't want to be confusing as I kind of subconsciously switch back and forth. Since the 1970s, the focus has really been on those subtypes, inattentive, hyperactive, or a combination thereof. In the 80s and the 90s, they've really tried to focus on the role of processing incoming information. In other words, when you get visual or auditory stimuli that come in, first of all, why does it not enter and be processed from the entry point the way we'd expect? And also, why is the output not what we would expect it to be? Also, why are outside distractions overly distracting to this population of kids such that they can't just look at something and come back to what it is that they were supposed to be doing? So they're really kind of looking more on the neurological basis, and we'll get into that here again in a few moments. I think it's really important for the kids with ADD to understand, okay, if you're having trouble with attention, what aspects of attention are we having trouble with? Remember, there's 4 main aspects of attention. The first part is focusing in. If you can't focus in on something, you're going to be really inattentive. So for example, the child who has inattentive ADD, the teacher may be doing a math problem on the board, and all of a sudden they hear a bird chirp, and they look outside and they say, boy, I bet that bird's up in that big old oak tree, and if I was up in that big old oak tree, I'd build me a tree house. If I built myself a tree house, I'd put up my St. Louis Cardinal baseball poster up there, because I think that's the last year we may have Albert Pujols, and that'll kill me. Wait a minute now. What is it that the teacher was doing? Well, I have no idea. And then they go on to something else. So that happens all the time. Now, in the younger grades, that's maybe not as apparent because the teacher makes sure everybody has it before we move on. But as we get into the higher grades, where today's lesson is based upon yesterday's lesson and will be the basis for tomorrow's lesson, it becomes an issue. The second part of attention is being able to sustain attention. If you cannot sustain attention, you're going to be very hyperactive. You'll see something, boom, you'll go to it. You see something else, boom, you'll go to it. So the boy sitting in class sees his friend Johnny walking down the hall, and instead of going, Johnny's in the hall, I need to catch him at recess to see if we have baseball practice tonight, he pops out of his chair and tries to go to Johnny. Okay? So it's kind of like my grandma said, you got to think before you leap, son. Don't just leap. Okay? So instead of ready, aim, fire, it's often ready, fire. When the kids have these impulses, they're not meaning to be bad, but they're just acting. Okay? So when we treat ADD and ADHD, we're helping the kids to be able to focus, and we're trying to get them to block out distractions. Then, in attention, you take information, you put it to short-term memory, then you take it from short-term memory and put it to long-term memory. A lot of kids with ADD have trouble remembering where they filed that information in long-term memory. A lot of times that'll come out things like spelling words or math facts, where the kids got the 15 words down that night. They wake up in the morning, they have orange juice and Cheerios, they're off to school, and they can't remember half the words that they knew stone cold the night before. Okay. So when we treat, all I'm trying to do is to help the kids to use their God-given gift of intellect to the very, very best of their ability in order to have them be able to focus, block out distractions, and remember where they filed the information. Okay? So now, how do we define ADD right now? It's observable behavior that features on a short attention span, distractibility, impulsivity, and overreactivity. Now, this little drawing here is to remind you, to tell you of a couple of things. This talks about potential areas of impairment all throughout life. The important thing to know is if you have ADD, unfortunately, we do not grow out of it. Okay? You will always have ADD. Now, if you're on medicine for ADD, that does not mean you always have to be on medicine for ADD. As we all know in the room, the older we get, the more we understand how our mind thinks. Okay? Using myself as an example, when I was in college, my wife didn't have any problem with studying with groups and friends, and they would sit in the library and ask each other questions and quiz each other and talk about life issues while they're studying. That drove me nuts. I wanted to be in a quiet room with a fresh cup of coffee and studying there. But I learned that by trial and error. So as we get older and understand how our minds think, we will, and when we reach that maturity level, do what it takes as far, example, environmentally, to be able to study. Also, it may be how we approach problems. If I know I have a short attention span, and I know that I can't cram my work in, I will take whatever my day planner is, and if I have Tuesday and Thursday available to write a report, then I'm going to block schedule time on Tuesday and Thursday to do that. So if a friend asks me to do something Tuesday or Thursday afternoon, I say I've got something on my schedule, I can't do it because I know I got to work on that report. Or if I'm studying 3 or 4 things at one time, myself, I'm going to study all of subject number 1, check it off, take a little break, go to all of subject number 2, check it off, take a break, then do subject number 3. The person with the short attention span may do part of subject number 1, their mind starts to wander, they take a break, go do part of subject 2, take a break, do subject 3, take a break, come back to subject 1. They're more efficient because it's fresh again. Okay? In that same study time that I cranked it all the way through and took a little longer break, they're going to be very efficient by breaking things up. Okay? But that takes understanding your mindset, being willing and having the personal responsibility to say, I want to have this career, I want to have this job, I want to go to this school, taking that personal responsibility to take it upon yourself to do so. And that's what happens with us as we get older, and those of us who have ADD. I'd say probably 50% of the folks that I have on medicine for ADD by the time they are late high school, college age, usually may not be taking medicine at all. I'd say probably of the remaining 25%, I have on non-stimulant medications for ADD, and the other 25% who are taking it are actually usually taking it at a lower dose than were taking it when they were younger in age. And oftentimes they just take it when they need it, meaning that they know that they have to, finals is a difficult time, or midterms because they have a lot going on, so they need to be more focused during those times. But on days where they don't need to be quite as focused, they don't have to take it. Okay, so it means that you have it, but it doesn't necessarily mean that you have to be treated with it all the time. Okay? So as we look in childhood, if untreated ADD, you can have academic troubles, relational troubles, they can have a low self-esteem because they think, gosh, maybe really something is wrong with me because I'm trying, but things just aren't working out. In adolescence, we run into injuries and smoking and substance abuse. Now, I pause there because one of the big questions that I've always been asked is if you use a stimulant medication, is that going to be a gateway drug to using drugs down the road? Very honest and appropriate question. The short answer is no. There was a large study published in Pediatrics, I believe it was about in 2003, where they did a meta-analysis looking at about 12 very big studies to look to see if that was the issue. And the short answer is it was not, and they found actually that the treatment for ADD was protective. It decreased your risk by about 50%. Okay, so they are not actually gateway medicines, but they actually prevent you. Because think about it, if the kids are focused, first of all, they may not get into that situation in the first place. And if they are in that situation, they're actually thinking before they leave. Okay? As we move into adulthood, we can see motor vehicle accidents, legal difficulties, and occupation and vocational issues. Okay? So what are the symptoms of ADHD? Well, looking at the general inattentive symptoms, you can see I've listed them here: careless mistakes, disorganization, difficulty listening, following instructions, or completing tasks. Avoiding tasks require a lot of attention, forgetfulness, and easy distractibility during activities. Hyperactive and impulsive symptoms include restlessness and fidgety behavior, intruding on others, speaking out of turn, butting into conversations, blurting out comments inappropriately, being impatient, and difficulty playing quietly. We can even further break them down looking at, say, well, kids are different at different ages. True, the preschool kids are going to have a lot of motor restlessness. That's like fidgety Philip. They may have an insatiable curiosity. Johnny, get away from that. Johnny, get away from that. Johnny, get away from that. And they keep going back to it. Vigorous and sometimes destructive play, because they're not thinking again how they may be tearing a toy up. Very demanding of parental attention, low level of compliance, excessive temper tantrums, difficulty completing developmental tasks, particularly toilet training, and decreased or destructive sleep, because they're just as active in their sleep as they are awake. Middle childhood is the usual age that I see kids being referred for ADD, and I see in there a lot of the behavioral as well as cognitive impulsivity, and that's the kind of rushing through my work. They're easily distractible, difficult to engage in off-task activities. They have difficulty sustaining attention. They can be very aggressive. They can act like the class clown. Now, we act like the class clown because it's easier to be laughed with, making fun of the teacher, making a comment, than to be laughed at because we have no idea what's going on in the classroom. And increasingly difficult relationships with peers because, again, the peers don't quite know how to read and understand the impulsivity. In adolescence, we see discipline problems and family conflict, anger quickly, and they also quickly have fluctuating emotions. They have difficulty with authority, significant lags in academic performance, poor peer relationships and poor self-esteem, hopelessness, lack of motivation to achieve or exert effort, and they also can have a lot of driving mishaps, speeding, and automobile damage. I take this as an aside. If you have adolescents or if you know an adult with ADD and they actually do better with the medication, there was a study published that was actually done, the Shire Richwood folks who make Vyvanse, Adderall, and Daytrana did the study, but they used the NIH and Navy flight simulators and made them driving simulators. And what they did is they took a group of folks who had DSM-4 criteria ADD, and they put them without medicine, and they put them through this driving test. And then they put the treated folks through the same driving test. Then what they did is they took a week. Those who were on the medicine were off for a week. Those who had not been on medicine took it for a week, and then they redid it. And they saw that there was a 10 to 12-fold increased risk of motor vehicle accidents and tickets if you did not take your medicine. Okay, so be aware that there really is some substantial benefit to adolescents and adults who need their medicine to take it on a consistent basis. So how do we diagnose ADD? Is this, the hard part about it is there is some subjectivity to it, so we do try to make as objective of a diagnosis as we can to help to minimize the subjectivity. First of all, we talk with parents and for the older kids, the patients, to interview ADD symptoms and potentially other disorders. We get collaborative information from other adults in other settings. For the kids, it's at school. For the adults, at work. We do a history and physical, diagnose other medical conditions. So, for example, hyperthyroidism you might mistake as being very hyperactive and overvigilant. There are certain genetic syndromes, Cre-du-Chat, tuberous sclerosis, Fragile X, which have an increased risk of ADD by definition of their genetic syndrome. We look at the DSM-4 criteria, which we'll look at here in a moment. Now, when I say assessment of educational functioning, I usually wait to do that. If I have somebody who I clearly think has ADD, and we have a conference and we decide to start medicine, I like to wait to start to do educational testing until I've started my medicine. And let me tell you why. Because I want to make sure I get truly the right assessment. Okay. Now, there are some folks, for example, who go to see the psychology folks where they're not only doing the psychoeducational testing, but they're also trying to look for ADD and the like. So if you're doing that, that's no problem. But for the folks who come to me, I usually do that secondarily. And I use the example of my glasses. Okay. God gave me my vision, but unfortunately I'm about 2200 with a worsening astigmatism in my right eye, so I definitely need these when I'm driving. Okay. If I try to take my driver's test without my glasses, I would uniformly fail it all the way through. Okay. If I put my glasses on and I can use my God-given gift of vision to the very best of its ability, then I'll pass my test. Now, say I'm still struggling with parallel parking, then the folks who are teaching me how to drive know, okay, he doesn't need global help, he just needs help with parallel parking. And when I'm getting that extra help, I can actually see the cones that where I'm trying to learn, so I'm actually getting more from that remedial help. So if I'm still having problems despite the fact that I'm on medication, then I usually go ahead and we'll do the psychoeducational testing. So I end up doing the testing in probably 10 to 20% of my kids, so it's a much lower number. We use standardized rating scales to corroborate the diagnosis as well as to look for comorbid conditions. And that's, for example, here we have what we call the Vanderbilt self-assessments. Basically, Vanderbilt Medical School put together these, validated them, and basically they were asking DSM criteria for things like not only ADD and ADHD, but looking for oppositional defiance disorder, conduct disorder, anxiety, depression, and the like. So we use these tools to, again, try to get more objective information along with the subjective information that we get from parents, the patients, and the teachers. Now, when I say other diagnostic tests are not routinely indicated, at this point in time, there is not a functional MRI or a PET scan or something along those lines that we can use to make that diagnosis. 5 years from now, that may change. Right now, it's not. So how do we make that diagnosis? To have the inattentive component, you need 6 of 9 symptoms. To have the hyperactive component, you have to have 6 of 9 symptoms. To have the combined, you have 6 of each. They need to be present for over 6 months. So for example, if you're in Hurricane Katrina and you try to go back to the classroom, you'd probably be really inattentive because you've been through a pretty significant trauma. But within 6, and that would be post-traumatic stress, right? But within 6 months, that should be, you should be back to being focused in the classroom. They need to be applicable in 2 different settings. Again, home and school is most common. The symptoms need to be noticeable before 7 years of age. Now, that's the most controversial criteria, because in folks who take care of adults, and I have a lot of parents that come back and say, you know what, you're really describing me when I was a child, and I think I need to be seen for that. Where do I go? And I refer them to my psychology, family practice, or internal medicine colleagues. The biggest thing for them is they may not have any way to document that they've had it before 7 years of age. So there's a lot of discussion of removing that as a criteria, particularly for the adults. And again, the symptoms are not the result of other disorders. So we break down ADD into 3 different subtypes. About 10% are purely inattentive, 5% are purely impulsive, the other 85% are combined. I argue that 100% are combined. You just have a little bit more of one than the other. Now, this is just a little quick slide to remind you that there is a little bit of overlap between ADD and learning disability, but it's not an absolute. About 2 to 10% of the general population will have learning disability. In several large studies, one that looked at a large number of kids being evaluated for learning disability who were also looked at for ADD, there was about 17% overlap there. In a different study where they were looking for ADD, but then they also looked for LD, there was about a 20 to 25% overlap there. So we need to look for it, but it's not an absolute. And that's why that's another reason why I usually treat before I test, because really what that tells me is 80% of the kids with ADD don't have learning disability, okay? So where does it come from? Well, mom and dad, that's where it comes from. There's about 80% penetrance in kids with ADD, meaning that when you do twin studies and they're raised in 2 different homes, 80% of the time both kids will have ADD. So there is a strong genetic component to it. And quite frankly, there's a lot of research going on to try to identify the genetics of ADD. Personality and temperament comes into play. If you are a very gregarious and outgoing person, you have the hyperactive component of ADD, that may be worse. If you're very introverted and you have the inattentive component of ADD, you may be even more quiet. Okay? Prenatal and postnatal factors, there are certain things. We talked about the genetic stuff. Also, for example, extreme prematurity, for example, 3 pounds or under, neonatal meningitis, things of that nature. There are some medical conditions that will put you at higher risk. And when I talk about brain structure and brain chemical differences, we're going to talk about that here in a minute, and that has to do with how your neurotransmitters respond in your brain. And I'll go into that more in just a moment. And when I say environmental influences, home life really does make a big difference. Kids with ADD do much better in a structured home environment where mom and dad are consistent with discipline, that they, with expectations, yes is yes, no is no. There's always room for mercy and grace, but they know what the expectations are, as opposed to where the kids are trying to find what their boundaries are, and there's a lot of conflict, because a lot of times the kids need even more medicine to try to overcome the home life than they really do to overcome what's going on at school. So when we look at the neurochemistry of ADD, there are two main areas of your brain that have to do with focusing and processing incoming messages, and that's your dopaminergic system as well as your norepinephrine nervous system. Now, the medicines that actually have the most potent effect actually work on both of those, and those are your mixed amphetamine salts, which we'll talk about in a moment. And basically what these medications do is they stimulate and potentiate the effects of both dopamine and norepinephrine at the synapse or the neuron level to help us to be able to be more focused. So let me explain what all that means. In your brain, in those areas, your brain talks to each other in what we call a synapse. And in that synapse, you have a message-giving neuron and a message-receiving neuron. And the neurons talk to one another by the release of a neurotransmitter. And what happens is that neurotransmitter is released, okay, sticks around in the message-giving neuron, passes the message down the pathway, then it is reabsorbed by the presynaptic or the message-giving neuron to be waiting for the next information to go down the pathway. A big problem with kids with ADD that we're seeing now is that neurotransmitter is, enough of it's released, but it's reabsorbed too quickly. So the full message is not passed down the pathway. So all we're trying to do with the medication is to help that neurotransmitter stick around long enough to pass the message down the pathway so the kids are making decisions with full information than partial. I use the example of if I'm driving down the road, my cell phone dies, and my wife's trying to give me directions on some place to go, and the phone's dead. I'm like, well, I've gotten this far, I guess I'm going to wing the rest. Okay. And so our kids are literally winging it on, I've got partial information from what's going on in this event. I'm going to try to do the best I can with not having anything else there. Okay. So that's how the medicines work, and that's what we're trying to achieve. Now that has to do with the stimulant medications and atomoxetine or Strattera, which is one of the non-stimulants that's a norepinephrine reuptake inhibitor. Your dopamine enhances signal, meaning it makes dopamine work better. It improves attention by improving focus, vigilance, on-task behavior, and on-task cognition or thinking. Medicines that work on the dopamine receptors are your controlled substances or your stimulants. Those that work on norepinephrine alone are non-stimulant medications, so those are non-controlled substances. The norepinephrine dampens noise, in other words, helps you be able to focus on what's going on by blocking out the distractions, enhances executive operations, meaning just that you're cognitively thinking more and paying attention. And again, that's what increasing inhibition means, is again, you're blocking out the white noise. Intuniv, which is guanfacine, and Capve, which is a long-acting clonidine, these are newer medicines on the forefront, and they are what we call selective alpha-2 adrenergic receptor agonists. What that just simply means is they work on receptors both in your brain and peripherally that do affect norepinephrine that helps kids with ADD to be able to focus better. Now, how does that work? Honestly, we really don't know. Okay, so there's a lot of research going on. We know it works, and we know it's safe, and we know it affects the norepinergic receptors, but they're not exactly 100% sure how that works. But it's not a central nervous stimulant, and actually these are medicines we've been using for quite a bit in their generic and short-acting forms for many years. The norepinergic effects for these medicines in the brain are what have to do with the effectiveness of these medicines. The peripheral nervous system effects has to do with relaxing blood vessels, and that's where a lot of times being tired and low blood pressure, which are the most common side effects of these medicines, come into play. Okay? Now, this poor woman has a little trouble with her car, and she's got to figure out how to get her car out of there without having that go in the drink and also limiting the damage to the boat there. So let's look at how do we manage then ADD, because that can be quite a puzzle. First of all, the American Academy of Pediatrics, as well as the American Psychiatric Association, has put together guidelines for the management of ADD. First of all, we need to establish a treatment program that recognizes ADD as a chronic condition, like we've already talked about. We need to specify appropriate target outcomes to guide management. The biggest pushback I get from potentially treating children with ADD is, first of all, from a lot of folks who don't understand ADD. Second of all, from grandma who doesn't understand the medicines, okay? And I say that because they say, well, I don't want to drug my kid for behavior, and I don't want my kid to be sitting in the corner drooling and missing life. And I agree with them 100%, because I am on the wrong medicine and have the wrong diagnosis if your child is not your child, and if your kid is in the corner drooling and not participating in life. In that situation, we need to totally reassess everything we're doing. My goal is to help the kids, again, to focus, use their God-given gift of intellect to the very best of their ability, so they're not getting frustrated in class, they're making good relationships with their friends and peers and authority figures, yet their personality is exactly who they are until they get to that point that they understand how their mind thinks, they're willing to do what it takes to manage their time and their lives off of medicine, and at that time, we make a switch to try it off or to try something different, okay? So that's why it's important that we have target outcomes to guide our management, and then we prescribe either stimulant or non-stimulant, in some cases both, and also include some behavioral therapy at times to improve our target outcomes for our kids with ADD. If the treatment program has not met those target outcomes, we know, hey, do I have the right diagnosis? So we need to look at that. We need to make sure we're using all appropriate treatments. We also need to know if we're actually adhering to the treatment plan, and we need to make sure, is there something else going on or a coexisting condition that I'm not managing? And then we need to use the information from the parents, from the teachers, and the child to really follow those target outcomes over time. So behavioral management does play a part. There was a large study called the MTA, the Multimodal Treatment Study for ADD, where they took roughly 250 children in 4 categories, so about a total of 1,000 kids, put 250 in a category being treated by medicine by community docs like myself, but they weren't doing it like we do it, where you're talking about doing a full assessment, where maybe the child will come in and say the teacher thinks Johnny has ADD, and they write a prescription. In those situations, without targeted outcomes and making sure you have the right diagnosis, the success rate was about 36%. Looking at a behavioral study where they did intensive behavioral therapy, the estimated cost per child was $30,000, where they had psychologists and they had parenting classes and camps where the kids went away for 6 or 8 weeks and the parents were part of those, they found about a 50% response rate. When you treated them the way we do, as far as from a standpoint of making sure you got all the right diagnoses and you're following and you have your plan, you had about a 76% response rate. When you combined the behavioral with the medicine, it was 78%. So my point of saying that is behavioral does have a significant component. And for folks who do want to try that route before medicine, I'm okay with that. But remember, you got about a 50% response rate on that. However, where I think behavioral management plays a huge role is in limiting the amount of medicine that I need. Again, if I don't have to use the medicine to overcome all the issues at the house, I can usually get by with much lower doses of medication. But our goals of cognitive and behavioral therapy is to promote social adjustment, counter negative self-image, correct deficits in academic skills, and decrease the stress with the parents and the family. So when we talk about medicine, I'll go over those pretty quickly. First of all, I'm looking for symptom improvement. Kids are the kids, but their symptoms are better. They're just more plugged in. We want to improve focusing. And when I say the 80-20 rule, that applies to pretty much anything. 80% of kids will respond to whatever medicine I put them on. 20% are going to respond better to one than another. So as we really try to decide what of the many medicines we use on the kids, we really need to look at the type of ADD they have, the sensitivity they have to the medicines, what are any other things that are going on medically for them, side effect profiles, et cetera. So we really try to tailor it even for that 80%, with the understanding that I could be the most tailored to what I think is going to work, and they still may fall in that 20% category. And when I say combination yields the best results, what I'm meaning by that is, again, some good adult parenting, behavior, action, consequence, along with the medication. So looking at the medications, we kind of break it into several different families. First is your stimulant family, and of that is your methylphenidate family. Your long-acting medicines last about 10 to 12 hours. The oral form is Concerta. 22% of Concerta is an immediate release, meaning it's available to the patient in about 20 to 30 minutes. And the other 78% is sustained release, where it's released at about 1 to 2 milligrams per hour over the next 10 to 12 hours. Then there's the Daytrana patch, which is a 9-hour patch, although you can use it for longer or less if you need to. that where the medication is absorbed through your skin and is released at a constant rate over the duration of the time that the patch is on. Medium acting, meaning that they last about 6 to 8 hours, is your Focalin XR, your Metadate CD, and your Ritalin LA. Ritalin LA and Focalin XR are 50-50, meaning 50% of the medicine is released immediately. The other 50% is released about 30 minutes later. Metadate CD, 30% is released immediately, 70% is released about 30 minutes later. And then your short acting is your Focalin or your Ritalin. What Focalin is it's a isomer. A lot of chemicals or molecules will have both a right and a left-handed side to it. Oftentimes, one of those sides is relatively inert. And so what they found is that in the methylphenidate molecule, the right side or the dextro side is the one that makes a difference. So what they're trying to do with that is to try to give a less total milligram dose, potentially with the goal of decreasing side effect. So that's where the dexmethylphenidate or the Focalin came into existence. Your mixed amphetamine salt family, quite frankly, is probably the strongest family of the ADD medications that we use. The 10 to 12 hour medications are your Vyvanse and your Adderall XR. The difference between the two is Vyvanse is absorbed into your small intestine, where Adderall XR is absorbed through your stomach. So there is the potential with the Adderall XR to have a little bit more of a food impact on the medication than with the Vyvanse. They're 50-50, so again, 50% is immediately available within 20 to 30 minutes. The other 50% is released anywhere between 3.5 to 4 hours later. The medium acting is your Adderall tablet. And then your short acting is your dexedrine spancels, or your Procentra, which is really just a brand name of the dexedrine. And that lasts about 3 to 3.5 hours. Looking at your non-stimulant medications, we have your atomoxetine or Strattera, which is once or twice a day dosing. Okay, that's the norepinephrine reuptake inhibitor. The Intuniv, guanfacine, and the Capvey or clonidine, those are, the Intuniv is once a day dosing, the Capvey is twice a day dosing, and again, those are the alpha-2 receptor agonists, which have been relatively new on the scene, although, like I said, we've used the generic guanfacine and clonidine. I've used them for 15 years as kind of adjuncts to therapy. There are some medicines that you may hear about that we don't really use much. Cylert was used when I first was coming through training, but there are a lot of problems with liver issues. And then some adult folks and family practice folks will use some antidepressants to help with these symptoms, either initially or in addition to the stimulant medications. So when we treat for the kids, it's really important that extended medication coverage is needed because we want to cover after-school activities, social interactions. We want to make sure that homework is being done. We also want to try to avoid the problems we run into with in-school dosing, privacy issues. I mean, the kids having to go and spend time with, go to the nurse and, kind of be ridiculed or made fun of because they're doing that. And that can decrease your self-esteem. Plus, you have concerns of storage of a controlled medicine in the school where you don't have any control, not sure where it's used. You want to make sure it's secure and it's not being diverted for other uses. When we look at using the medications, it's important to know a couple things. There is a large therapeutic window, meaning that, that there is a big dose range for which these are effective, which again helps with their safety profile. These medications are also not considered to be physically or psychologically addicting, meaning the kids don't wake up in the morning and their body feels like they have to have a stimulant medication. Or they're not psychologically addicting, in other words, they don't think they have to have that. Unlike all of us who drink coffee, myself included, I'm going to get a raging headache if I don't have a cup of coffee, and I know I'm going to be awful tired. So that is a safe aspect to them. The medicine is out of their system when they wake up in the mornings, okay? And so there is no cumulative effect in the body. Now, there are some medicines that does take a little while to see the effectiveness, particularly the non-stimulant medications. But again, still, if a side effect occurs you don't like, quite frankly, we just stop it. On the higher doses of the Intuniv and the Capvey, sometimes we will step those down a little bit, only if we're concerned about, if they're on a high dose, if we're concerned about blood pressure issues. But I've had kids just stop them, and they've done just fine with that as well. There's no loading dose. There's no weaning period. And like I said, these medicines have been studied for, on the average of 7 to 8 years before they come to market. So, and when you think about these new medicines, think of them as old medicines we've been using for 60, 70 years. But we're just a whole lot better at delivering them to minimize their side effects. So they really are safe and effective. My thought process is I always start low and go slow. I give a dose in the morning. I want to see how long does it take to work, how well is it working during the day, and when does it wear off. So I'm monitoring behavior and learning in the first half of the morning, second half of the morning, and then after lunch. And I usually take about 5 to 7 days, given 5 days of teacher input and 2 days of home observation, to see how they do, because inconsistency is a symptom of ADD, to see what and when I need to do any changes. Obviously, again, I tell my folks, if there's a side effect that occurs that you don't like, simply stop it and give me a call. Most common stimulant side effects, again, these are all dose dependent, so by starting low and going slow, I can minimize them. And also with the more sustained release medicines, it also does help. But appetite suppression, high blood pressure, heart palpitations, headache, stomach ache, particularly if we're not eating, we just aren't hungry, and so if your body's not responding to the hunger issues, you get headache and jitteriness and stomach ache. So a lot of times by just making sure the kids are eating and getting an after-school snack, that usually helps that quite a bit. Somnolence and lethargy usually occur with the short-acting ones when the dose is too high. I can see increased emotional ability, particularly with the mixed amphetamine salts in the younger kids. Motor tics and Tourette syndrome, what that means is that those are little involuntary muscle contractions that what happens is the stimulant medications decrease the body's ability to inhibit those. Once you stop the stimulant medications, the body's ability to inhibit those muscle contractions returns. So it's not a cause-effect, it's an unmasking. So it's just something to look for. And also, if the medicine's around too late, the kids can have trouble sleeping. On the other hand, I have some kids who take the medicine almost right before they go to bed because they can't sleep, because their mind doesn't slow down enough if they don't have a little stimulant medication or non-stimulant medication on board. So side effects of our non-stimulant Strattera, most commonly I see is upset stomach if you take it without food, so I always make sure folks eat before they take it. In adults, Strattera is usually the most common non-stimulant medication used in adult patients with AD. You can have some elevated liver functions in adults, so if you have right upper quadrant pain, or if you have an adult patient who's consumes a moderate to large amount of alcohol or has liver disease, it'd be important to maybe follow liver function studies. There is a black box warning because atomoxetine was used in the past as an antidepressant, found it didn't work for that, and so it was taken off the market for that. And then once the understanding of the norepinephrine reuptake inhibitor component of working for ADD was found to be effective, that's when it was brought back on the market. But because it's a cousin of the SSRIs, the Paxils, the Zolofts, the Prozacs, that there is that black box warning that if your child gets emotionally labile on it, just stop it, because there is a slight increased risk in adolescents and older and young adults of increased risk of suicide. So just be aware. Intuitive and cat-bay sleepiness and low blood pressure are the main side effects that I've seen. Now, this is a little slide of High Point Central High School, where my son is graduating this June, to remind me to take a moment to go over very quickly for you some classroom modifications. Now, I know I go through these things pretty quick, so I do have, and I know y'all have been taking notes, I probably should have said before, I do have a few handouts. If you need handouts, ask Mary Beth or Pam. I can get things for you, because again, us docs, we put as much on a slide as we can and carry as many of these as we can. So focusing on a couple things. First of all, memory and attention. Have the kids sit closer to the teacher up in the front of the class. Make your oral instructions brief. Not a big, long explanation, but short and choppy. They'll understand that better. And you may need to give more than once, and don't get frustrated if that happens. Provide written instructions when you can, particularly if a report is due or an assignment or a project. When you're doing a math problem, help them to break down the math steps, doing one step at a time. And don't hesitate to use visual aids, because a lot of these kids are more visual learners than anything else. Again, when working with memory and attention, I say kind of walking the child through assignments to make sure he or she understands the task. And again, just like I described how a lot of my college and high school kids study in snippets, you may need to do it that way as well. Break up the tasks and homework into smaller steps. We want to teach active reading, which is underlining. My wife would think that I have ADD from a standpoint of how much I underlined all my medical school books. They're like her bright, active colors. Active listening, in other words, taking notes, and reading for detail. And also providing remedial help in short sessions when needed. A lot of this, by the way, can be obtained by what we call a 504 plan. So if you have kids with ADD or ADHD, a 504 plan is basically under the, it's a plan where the kids are able, under the American Disabilities Act, where Section 504, where the kids are classified as other health impaired, which means that the school districts have to provide environmental and academic things for the kids that will help them in their classroom. So for example, I always tell folks, get a 504, we want preferential class seating, we want small class sizes, we want access to tutoring, we want the kids to be able to take untimed tests, particularly the EOGs, and to be able to maybe have them do those in the library as opposed to having them have to be done in the classroom setting, because all those things can be stressors for the kids. And these are for kids who don't necessarily need an IEP, which is an individualized education plan, which is a whole different ball of wax. But I do try to encourage my folks to talk to the schools about getting, if there's any concerns about academics, to talk to them about getting a 504 plan. And I also have some nice little nasty letters if y'all need them to tell them if they're resisting. They work real well. To do impulse control, we want to remind the student to slow down, especially on a multiple choice test. It is not a race to see who can get to question number 50 first. We want to teach the child to monitor the quality of their work before turning it in, meaning check your answers. The classroom atmosphere, we want to have it structured, clear expectations for when and how tasks are to be done, and reminding the kids in advance of what they're supposed to be doing. We want to have moderate and consistent discipline. Again, all this works at the house too, where there are clearly stated consequences for unacceptable behaviors. We want positive reinforcement for good behavior, which again, the goal of that is to try to minimize any negative sanctions. Organizationally, we want to have a daily checklist for tasks. And I tell folks, find out what works best for the kids. So when we're talking about organizing, do they organize better on an iPad? Do they organize better written? Do they organize, how do they, on their computer? Find out what works for them and help them to develop that organizational skills, because what may be good for them may not exactly be what we would prefer. Homework notebook, important to have those where you can see a list of daily assignments, what's the date due, and make sure all the necessary resources are available. I tell the folks, have a morning binder, and if it's too big to have one for all day, have an afternoon binder too in different colors. So basically, if it's language arts, everything pertaining to language arts goes in and out of that same language arts folder, so all the kid got to do is remember is bring home the folder. And then everything goes in and out of the same. You'd be surprised how many times that doesn't work, but it's a good place to start. And again, it's really important for us and to elicit the help of the teachers to follow up on homework not turned in. For productivity problems, we want to divide the worksheets into sections, as we've talked about, reduce the amount of homework and written classwork. What I mean by that is not necessarily the work that the kids need to be able to learn the material, but a lot of times there's repetitive work that the intention is to solidify concepts, but a lot of times for the kids with ADD, if they've already got those concepts, it becomes busy work and becomes very frustrating. And I use the example, my kids when they were in elementary school used to come home with their vocabulary words where they had to find them in a word find. Okay. That did not help them to learn the vocabulary words. They just had to find them in the word find, and it took them 30 minutes to do that. And so that's the kind of thing that really isn't going to help our ADD kids. They're going to get very frustrated because they can't find that word right away, and they're going to be ready to move on and do something else. We want to also decrease the number of math problems that must be completed if the child knows how to do them accurately. Again, reinforcement is important, but repetition for busy work is not. In written expression, we need to allow extra time to complete written tasks and assignments, provide special help with handwriting. A lot of times the handwriting gets a lot better with medicine management, but still a lot of times I'll actually refer the kids on over to the occupational therapy folks, and they can also help the kids with handwriting. Allow the student to dictate reports and take tests orally if they need to. Again, a lot of them are visual learners and respond better orally. And we want to, again, reduce the quantity of written work the child is expected to produce if it is not necessarily a productive thing. Looking at self-esteem, we want to reward progress, even if the actual achievement does not meet standard requirements, meaning that we're not really exactly where we need to be, but we're making progress, reward that progress. Encourage performance of children in their areas of strength. So if they really struggle in math, encourage them through math, but if they love arts and music and things or athletics, man, encourage them to do that. And so they'll really get a lot of build up in their self-esteem and will be less frustrated in those areas where they struggle. We want to avoid humiliation, meaning that we don't ask them to perform tasks in front of others they can't do. If math is a struggle, the teacher shouldn't have them go up to the front board to do the math problems. but if English is their strength, let them do 2 times the sentence structure on the board. We also don't want to have them have other students grading their papers, particularly in areas that they're struggling. And we want to, and also it's really good to kind of give, the teachers can give hand signals that only the child can see as private reminders of appropriate behavior. I had my child's 4th grade teacher was very good at this. What he did is he had all the ADD kids in his room, and he had about 8 of them. And instead of making the classroom long ways, what he did is he made it short ways where he had like 8 desks going across, 3 desks deep. Put all the ADD kids on the 3rd row. They were still close enough that he could see them, they could interact with them, but they wouldn't bother the kids who didn't have ADD. Now, he didn't mind if they were, sitting all sideways and moving around, as long as they did not interrupt the class. But he had separate hand signals for the kids on the back, where he could be talking and giving his lecture, and if his hand went up like that, all the kids they knew, sit down, y'all being too loud. Things of that nature where it didn't have to interrupt the flow, nobody was called out or being embarrassed, and that really worked quite well. So I gave him tremendous kudos for that. Social relationships, want to provide positive feedback about behavior in situations involving other children. Really important to coach them. If our kids are having trouble with some behavioral things, giving them clues or times where they, when you're sitting and talking to them, so which they can say, okay, well, if this happens, Mom and I talked about I should do that, as opposed to relying on an impulse or a reaction to respond. Make sure the classmates do not feel that the child with ADD is getting away with less work. That would also go with siblings, or worse behavior. Remember, yes is yes, no is no, consequences apply to everybody, all the rules are the same for everybody. So it's important to make accommodations when necessary, but if there's an accommodation that's made for one, they really need to make sure that is consistent and applied to everybody. Because remember, all of us are responsible for our actions, and it's important for our kids to learn that at the very beginning. So that being said, I appreciate your time and attention. And I wanted to see, I know I ramble on quite a bit, so this is your time. Questions that I can answer for you all about something about ADD, something we didn't talk about, something that wasn't clear. What questions can I answer? Marty.
Benefits with biofeedback. Do you have anybody that that does biofeedback?
That's a great question. Benefits to biofeedback. I've had one patient who has had a biofeedback be beneficial. A lot of times with the kids, although they can do pediatric biofeedback, it's not been terribly successful. So I don't know, that may have more to do with the adult population. Where I think biofeedback would be helpful has to do more with stress reduction, because it's in anxiety, meaning that, as you know, if you're inattentive, you're going to be anxious, and when you get more anxious, you get more inattentive, and then you're more inattentive, so you get more anxious, and it kind of becomes a vicious circle. I have a lot of kids who come to me with both symptoms of anxiety and ADD, mainly the inattentive aspect. So my question is, what do I need to treat first? Do I need to treat the anxiety first or the ADD? And we kind of sit down with the parents and individually treat one versus the other. If the patient has a pretty significant anxiety component to it, treating a trial of biofeedback is very reasonable, because you can always go to medicine. But I think that's probably where that's helping more so. So it's a secondary attentive help as opposed to a primary. Okay? Paige.
There was a 60-minute segment on these drugs being taken by children that don't need them, or particularly college students. So do parents need to be particularly careful about their drugs not getting on the black market, or comment on that?
The question had to do with actually the abuse of stimulant medications by high school and college students being diverted for uses other than their intended. And the answer to your question is, yeah, that is a big problem. Because although the medication's working on the brain, helping the kids who need it to be able to focus, it actually helps the kids who don't need it to be even more focused. So a lot of times the college kids and sometimes the high school kids like to use that when they're trying to pull all-nighters. The problem that they don't realize is that may help them over the night, but then they end up crashing the next day. And so it actually is a counterproductive situation. The other thing too, when they're not used in the proper manner, these kids may have some other medical condition that would make you not want to use one medication but instead use another. And if they don't know what those are and they're not under the care of a physician, that can be a problem. So it is very important for the parents to be in control of the medications, to keep count of the medications. It's very important for the parents when the kids are in college to be sending them just what they need, be it for a week or for 2 weeks, and not sending them with large quantities. And quite frankly, a lot of the kids who've been on the medicine who are a little bit older understand how much it really helps them when they need to keep it. So they don't tell anybody they're taking it because they don't want anybody to ask them for it. But that is a problem, and most people who ask for it or inquire about it are people who don't have ADD and have just, heard about it. But that is an issue, and it's important for the parents and the providers to keep track of that. And so we're all encouraged to keep very accurate records for when we've done prescriptions, how many we've prescribed, et cetera. Okay? Yes.
I have a question. My daughter is more the ADD, and she's been diagnosed since she was in 3rd grade. Well, one problem, she's 17 now, and one of the problems that we're running across, she's on Vyvanse,
Mm-hmm.
and she takes it Monday through Friday. But then on Saturday and Sunday, she just refuses to take it. She's 17, so she pigs out all weekend long, of course.
Sure.
But the thing is, she's like a zombie all weekend, and we cannot get her motivated. She just wants to stay in her PJs and sit on the couch and watch TV. And I know it's because, it's the medication, and I don't know how to, we need to have a more productive life with her.
Right. The answer to that would be, you could do, suggest a couple things. First of all, having that conversation with her to find out what is it about the medicine that makes you really want to take a break on the weekends. There's a couple different things that one can do about that. Number one, if she's a little higher dose, say, and I'm just making this up, say she's at 40 milligrams during the week, well then maybe we drop her down to 20 milligrams on the weekend. So it's enough to help her to stay focused enough to say, okay, I know I gotta do my homework, I have to do my projects, et cetera, and I'm not just gonna blow things off. On the other hand, if she's worried about appetite and things of that nature, she'll still have more of an appetite. It would also be a potential that you could use an Adderall tablet, the shorter acting Adderall tablet, to say, we're just going to use that because I know you got this project, so we're going to plan on you doing this Sunday afternoon after we go to church, and so I'm going to give you a short acting Adderall tablet before, after church, and we'll plan on doing it then, but the rest of the weekend is off. It would also be a good time to think about doing a non-stimulant medication. And it also may be a situation where over the summertime, changing to a non-stimulant medication may be an option. So I'd kind of maybe talk with your daughter's doctor and see what those options may be. Yes?
I just wanted to share something, more of a comment. If anyone's interested, there's a really good book out there. It was funny because my 4th grader brought it home and he was reading it with his class. It's a very easy read because it's elementary level, but it's Joey Pisgah, Swallowed a Key.
Uh-huh.
Have you?
I have not read that. I haven't read that.
It is about a boy with ADHD, and it's from his point of view. And it, part of it is the doctors say I'm wired wrong, so I'm wired all the time. It's really cute, but it's very informative, and it's really neat. It teaches other children how to understand and take classmates like that. It was just a really good read.
That's great.
So
That's
I thought
great.
I'd mention it.
Thank you.
Is there any correlation as far as certain dietary things, dairy versus non-protein, dyes, no diet, those sorts of things?
Dietary effect, that's a great question. The answer to that is it can affect people individually, but not globally. In other words, when they've done research to say if, using red dyes, for example, they've done a big population study, red dyes in a population didn't make a difference, but I have some families that'll tell me, my kids can eat M&Ms all day. They eat one red M&M and they're crazy. They can drink Kool-Aid all day long, and I give them one sip of red Kool-Aid and they're wide open. In that situation, I say, well, avoid the red dyes, because so it's more of an individual thing. So, it's always a good idea to decrease your refined sugars. Making sure we're getting plenty of activity, make sure the kids are getting plenty of protein in their diet. Trial to avoid things has been helpful. I've had some folks that have tried gluten-free diets. That hasn't, really helped much on the whole. I put that in the category of it's certainly going to hurt if you want to try it. If it helps, great. If it doesn't, don't be frustrated, because those are more kind of individual things as opposed to population that applies generally to a population. Okay.
I have a question. My grandson's
of Vyvanse? Uh-huh.
It affects his speech. He has almost to the point of having to have speech therapy.
Huh.
It's sort of, he's 12 now, and he's been on different things. But you can actually just sort of see it working on him.
That's a situation where he's probably overthinking what he's trying to say before it comes out. So he may be hyper-focused on that. So my thought about that would be potentially decreasing the dose a little bit. Again, not knowing what he's tried, there are other, maybe looking at different medicine, or that would be the prime situation where you might decrease the dose, add a non-stimulant to continue to get the benefit of my focus, but maybe decrease my side effect profile.
She said about her grandson starting at age 4. Is there a minimum age that you think we really should be putting those kids on that?
I have I take care of a large number of kids. When you look at the data, the average age of onset is 4. And that just simply means if I go all the way back and I see when did my symptoms really start, that I could really call it probably ADD was 4. Not necessarily all the kids are not necessarily diagnosed and put on medicine at 4. Most of the kids I wait till we're in a school setting. There are a handful that are obvious, and we've done everything. We've done the counseling, we've done the behavioral mod, we've done, and it's really adversely affecting the child and the family, and in those situations, I will try it. So I probably have a handful of kids on 4 at 4. 6 to 12 is usually the most common age where we'll start medicine.
Sorry. Is there a correlation between, I have one child that has ADHD, he's in 2nd grade, and now I'm seeing some things in my kindergartner. Is there a percentage among siblings? I know you mentioned the twins.
Well, it's not necessarily sibling to sibling, but the 80% penetrance from mom and dad. So the answer to that is yes. Yeah, there's a much higher instance. I can't give you the exact number, but I'd be looking for it.
I have one more question.
Okay,
for you.
sure. I'm good.
Do you see a relation in like some kids who have ADHD and like OCD?
Yes.
Kinda like
Yes.
There's
There's a
that a little bit with my dog.
Yeah, when you look at the comorbidities of ADD and ADHD, OCD or obsessive compulsive disorder, there's depending on what you read, there's about a 20 to 25% chance of OCD. The highest one is ODD, which is oppositional defiant disorder. The problem I have with it, and that's up to about 50 to 60%. The problem I have with that is a lot of times when people diagnose that, that's at the same time they've diagnosed the ADD, and those are really impulsive behaviors. If you redo that questionnaire when they are taking medications, all that's gone away. But OCD, anxiety is about 20 to 25%.
And do you see like when they do go on their medication, sometimes the OCD kind of goes up a little bit?
If it does, that would be an indication, again, to either try something a little different or to potentially add, to try one of the non-stimulant medications where you wouldn't run into the anxiety issues. And I do have a number of kids who I do put on a little bit of anti-anxiety medicine like a little sertraline, FDA approved down to the age of 6 for OCD, panic disorders, and anxiety, and I've had very good success with that. And I say this from a safety standpoint of a lot of my autistic kids who are baseline extremely anxious, that when I put them on just a small dose of sertraline, the adult dose is 50 to 200 milligrams, and I'm talking 25 to 37 and a half. They do beautifully, and they can be really big kids. So there are options to look at that too, whether it's changing medicine or maybe adding a little something if we need to.
And when you, what other kind of, what's some name brand of some of the medicines?
Zoloft.
Zoloft, is it the number one for you?
For myself. Now, other people may give you different things, but I think that's the safest and I've had the best response with.
Okay, great, thank you.
Okay? Thank you all very much.